fall semester. It's a pleasure, and I just actually met Dr. C, we can call you Dr. Catherine, and she'll explain how to pronounce her last name. I just met her today myself. It's a pleasure to introduce her. She's a professor at the Pennington Biomedical Research Center, works in the area of nutritional epidemiology, dietary assessment, and counseling. So with that, I'll let you start your presentation. Thank you.
Thanks.
Thank you all for coming.
I'll begin by telling you that the NPR called, well, the WRKF called me up and they said, we need to know how to pronounce your name because they wanted to promote it. So I said, well, sometimes it's champagne, and if you're in Acadiana, and the young lady told me that she was from the Lafayette area, it's champagne. So I've been listening to the announcements, and it's champagne. And I'm trying to figure out, well, you know, I think maybe the safe bet is to use the English pronunciation because everybody seems to know a little bit about champagne, that bubbly stuff.
Not this much.
Maybe not this much. How many of you attend University Presbyterian Church and have heard me give this talk in May the 3rd last year? I thought I recognized a few people. And so this is the exact same talk. Maybe your
repetition always helps.
Well, it's always a good thing, I guess. But when I was called, I said, well, I gave a talk like this. Oh, it's a different group of people. So at least there's only 2 repeats, so to speak. What I'm going to talk about is some work that we've done in the Delta and some work that a student of mine did in the Baton Rouge area. Our Delta work focused on the lower Mississippi region of Arkansas, Louisiana, and Mississippi, and it's the Delta area is pretty impoverished. In particular, if you look at it's always the bordering the 3 states, and you know those areas, for example, West Carroll Parish and East Carroll Parish in particular have been sometimes termed like third world country, sort of, because it is so very rural and impoverished. But we have had this particular initiative going on since 1995. We are actually taking a little variation of that. We're now we're calling it now the Delta Obesity Prevention Research Unit. So we're actually, the focus is now on obesity because even in some of these rural areas we see high levels of obesity. Just a little bit about the region. It's you know, a rural, as I said, and there's specific demographic subgroups that are at greater risk for health problems, and you can see some of the housing is perhaps less than desirable. But what we've done, we did a baseline cross-sectional telephone study survey, and we had a stratified cluster sampling plan. What it means is that, do you know what that is? What it is we have 36 counties that comprise that whole area that I showed you. And so when you do a cluster randomization, you actually limit your survey to half or less than half. And the assumption is that if you have 2 counties that represent a cluster, that they have very similar demographics. So obviously it takes a lot of resources to actually interview people in all those different areas, but we did form 9 strata, and they were similar in the percent African American, the percent that lived in poverty, and the percent that was urban, very little urban areas. What we did was we did a household screener. We called people up, we got their household information, we took dietary recalls. We did a food availability and opinion survey, and we also looked at beliefs about nutrition and health and religious beliefs as well. We collected information as to whether they participated in a nutrition assistance program, and we actually implemented something that has been proven to be very valuable in this particular research is we tried to figure out what their level of food security was. Were they secure? Did they have as much food as they needed? And if yes or no, then we sort of explored that in a little bit more depth. So we define food security as access by all people at all times to enough food for an active, healthy life. The food is readily available, it's nutritionally adequate, it's safe, and it can be acquired in socially acceptable ways. And that you can imagine what that means. So you can go out and buy it as opposed to stealing it or whatever, or rummaging around garbage cans. Food insecurity is defined as limited or uncertain availability or nutritionally adequate and safe foods, or the uncertain ability to acquire foods in socially acceptable ways. So what we found too was that sometimes you might be food secure some of the time and food insecure some of the time. So your level of food security may depend upon whether it's the beginning of the month or the middle of the month. Many, many factors. So what we found in the lower Mississippi Delta is that the Delta had a higher prevalence of food insecurity than the rest of the United States. You can see that overall the U.S. is about 12%. I think that's looking at 10, but we found levels of food insecurity above 20%, which that has been really alarming to us. If we look at food insecurity by income, obviously you see that the lower the income, the higher the level of food insecurity. By race, we did see a difference in race, that African Americans within the Delta were significantly more food insecure than African Americans in the whole of the United States. Now, when I tell you this, the whole of the United States, this is really based on a lot of data that we have gotten from, the overall survey of Americans. So the food insecurity module has been assessed in many, many overall population projects, and so we're comparing what we found to overall, which actually may include some of the people in our area, but not as too extensive a number as we included in this particular survey. We also have been looking at children, and so I think that yes?
Just before I lose track of the question, you used the phrase nutritionally adequate several times. Can you say a little bit more about what that looks like?
Nutritional adequacy means that you can get good food, healthy food that is like fresh fruits and vegetables, or even fresh, canned, frozen, and you can get foods from each of the food groups. Like you can get fresh, like dairy, dairy, meat and beans, fresh vegetables. And I think the other thing is like, when we talk about grains, they get a lot of grains, but they're not the right kind of grains often. At least not the kind that we're necessarily promoting. So we also see that the children, because we have asked we asked the food security module, I believe we asked that regarding the children in a larger age group of children, and maybe verified that with the adults. So we did see then that, yes, children in the lower Mississippi Delta were certainly much more likely to be food insecure as well. It looks a lot like the other data. So when we looked at our study, and we looked at what people were eating, these are the 10 top contributors of energy intake within that survey. Soft drinks, bread, hamburgers, fried chicken, salty snacks, fried fish, cornbread. Cornbread's good, actually. Fried eggs, pasta, and French fried potatoes. I think when I think about food preparation techniques, for instance. Fried foods impart more calories, and if you're hungry and you want more calories, you're going to see them selecting some fried foods because it actually helps to make them feel fuller longer. So not necessarily the best nutritionally, but I guess it meets that calorie expectation. We looked at fruit and vegetable consumption, and we found that on average, less than 1 serving of fruit per day. Better in vegetables, 2.8. Now, you know, in the United States, we're pushing, actually, it used to be 5 a day, but now it's like 9 to 12. So if you're indexing 5 a day, these people are like closer to it, but if you're looking at 9 as the bottom line, then they're definitely not getting those 9 servings of fruits and vegetables. Now, part of it is, well, and I'm going to go into what part of it is later, and I don't want to keep you here too long, but I have a lot of slides. So, alarmingly, potatoes within the USDA database are considered a vegetable serving. And so if you break out the vegetables and you break out the potatoes, you have a lot of French fries contributing to that vegetable intake in terms of potatoes. This is a little bit busy slide, but I think that we need to know about health-related status, food choices. You know, that it talks about agricultural policy, food environment, and social environment at a community level. Different characteristics at the individual level all factor into your food security status, your choices of food, and then you go from there to your actual nutrient intake, and then subsequently or eventually your status in terms of nutrition biologically. The community level influences, some of the environmental influences have really factored into some of our research, and we are realizing that the availability of food stores and food stores that are large enough to have a variety of nutritional foods have been really one of the things that have been revealed. And you think about it in a rural area, if you're driving through, it doesn't have to be Louisiana, it could be West Texas. If there's a long stretch of land, you might not see, if there's no people, there's no food, or if there's a few people, there's still no food because there's not enough demand. Institutional influences, schools and school meals and churches. In some of our data that were collected on children during the school year, because they weren't collected, this survey in particular was collected during the school year, the children fared pretty well, all due to school lunch. So say what we want about school lunch, some are saying it's bad food, but at least we found that the level of intake was better because children were getting school lunch in these rural areas. And churches sometimes provide meals on a weekly basis for their congregation. And then socially, behaviors and beliefs of family members. I know that there's lots of things in the media that sort of make you believe that, some people, like my mother used to say, you can't eat oysters and drink milk. So, it was like you were going to blow up or something, but, the bottom line is I don't think there was any valid grounds for saying that, although she just didn't like it. The community level influences in terms of food environment, and I said availability. The other one, the last one was access to, it's one thing about getting to the store, and then the second thing is what's available in the store. So that's where the food availability comes in, the accessibility, and of course, if you're in a low socioeconomic status, the price of the food is very much a significant factor. Social environment, beliefs and behaviors of significant others. How many of you have that as an issue? This is when I was growing up, I always liked to, give you some, not too much information about me, but my father never let us have mashed potatoes in the house. Never a mashed potato. And the reason was he had peeled so many potatoes in the Army that he did not ever want to see a mashed potato. So we as kids liked mashed potatoes, and so we'd have to wait for him to be away from dinner before we got mashed potatoes. So, you know, those are the types of things that really dictate what happens within a family. Cultural values, media and advertising. Where are the sugar-coated cereals in the grocery store? The bottom shelf in easy reach of the children. So media has a lot to do in terms of dictating, you know, certain things, and that's one very good example of it. Social norms and context or you know, another. The individual level influences, I think, are actually are very strong in terms of, you know, taste and food preferences. How many of you as a child like broccoli? Few of you. But, you know, I mean, with my own children, I had to pour a little cheese sauce over the broccoli because, you know, they kind of have to make it. And then here in the Delta, you know, they add sugar to everything. They put sugar in butter beans, sugar in field peas, because they know the food is good, but they need to figure out a way to make it more acceptable, especially for young children. I think that as we get older, we sort of enhance or broaden our acceptability of foods that are more nutritionally adequate. Preferences for energy-dense foods transcends culture, ethnicity, and geography. You know, we've done a lot of work at Pennington with African American populations, and you know, you can't. But it's not just African Americans. It could be Hispanics. It could be Caucasians. You know, you can't disrupt people's traditions. You can't say, oh, you can't ever eat greens prepared with ham hocks, or you can't have cornbread. I mean, you cannot do that to people. You actually try to modify them so that they become more nutritionally acceptable and better for you, but you know, things like cooking it for an hour really kind of, almost any vegetable, it's not really the appropriate thing to do because you lose a lot of the nutritional value. 99% of customers indicate that taste is important when they purchase food, and I think that you'll agree that taste is very important. I'm going to show you some data which you guys have already seen, but more information about taste being the #1 thing that is the most important factor. Life experiences are also important. Your childhood experiences with fruits and vegetables tend to somewhat shape you as adults, but we can change that. It's kind of like change is good. For here even. Learning history with foods and eating experiences influences adult eating patterns. I've heard of people, of children actually. This one old lady that I knew did not like eggs, and her the table had like a little drawer underneath the table, and she would scrape the egg in there, but you know, after a while the egg started smelling pretty bad, so you know, she got caught. The socio-demographics, I think we have to look at the relative importance of cost and convenience that are related to your age, your sex, your income, your ethnicity, consumption of fruits and vegetables, fast food. These are all things that we see very prominently. In fact, that's the first thing I saw when I walked down into this building was fast food. And you know, I've been on this campus for more than 20 years, but I haven't been here regularly for the last 20 years. I, you know, did a lot of work back in the late 70s and the 80s. It was, you know, different. And I don't know that this is better than what it was back then, but in any event, I think, but we do see, and so that's evidence that it's even come into that. And you know, and we're doing a lot of work with Army nutrition, and we see the same thing that you see downstairs in Army facilities on Army posts. So there's, I think that this is a disturbing occurrence in that, you know, it's going to, that these fast foods are going to replace better foods, I think. Not so good. And, you know, obesity is a problem, and I don't think this is going to help it. But we also find that consumption of low-fat diets is higher among women, among Caucasians, and among older adults, because I think that as you reach a certain stage in your life, you start having problems, you know, like maybe you start worrying about maybe your bones, because somebody you know has osteoporosis. So I think the issues of aging, when affect us, because then we start thinking about wanting to live a long, full, high-quality life, and we're not going to do it with McDonald's necessarily. And I'm not knocking McDonald's. They have some good things that they offer there. But people are not necessarily thinking healthy when they step foot in the store. So, is food insecurity linked with disease, obesity, and health? I think this is some data that we collected in the Delta. You'll notice that if we look at the diabetes, hypertension, and obesity, those are the three headers up there, that we found that that males had, that there was a higher incidence of diabetes in females than in males, in African Americans as opposed to whites, in lower socioeconomic status individuals as opposed to higher socioeconomic status. In terms of hypertension, you see again that in the Delta, that women have a higher rate of hypertension than males. Again, African Americans higher than Caucasians, and same thing for income. The trends are the same. The obesity percent was, income was not a factor, if you notice this. So it didn't matter whether you're rich or you're poor. There was not a significant difference regarding income, nor whether you were male or female. There was a significant difference whether you were African American or white. When we looked at people who were obese and their food security status, you can see that those who reported that they were food insecure had a higher level of obesity. So this is telling me, in fact, I've often heard it when Mississippi, a number of years ago, came to the forefront in terms of having the highest level of obesity in the nation, based on data from the Centers for Disease Control. They interviewed my boss, Dr. Donna Ryan from the Pennington Center, and her response to the interviewer was, well, what do you expect? French fries are cheaper than fruits and vegetables. So, you know, the expense of good food is somewhat dictating this as well. If you look at those who had heart disease, the metabolic syndrome, do you know what the metabolic syndrome is? Have any of you?
Obesity, diabetes, and hypertension.
Actually, the definition of the metabolic syndrome is related to 5. It could be waist circumference, how big you are around the waist, diabetes or insulin resistance, hypertension, triglycerides, and maybe there's one other one, BMI, I think, obesity. So if you have 3 of those 5, then you have the metabolic syndrome. But it's mostly, you know, abdominal, you know, carrying the little bit extra in the stomach. But you can see that when you look at the level, and this is all data from they reported that they had, we asked them questions about whether they had heart disease. You know, we asked them questions that helped us to determine whether they were at risk for metabolic syndrome or had metabolic syndrome, and we asked questions about stroke. So you can see that those who were food insecure actually had a higher chance of heart disease, metabolic syndrome, food insecure, and stroke. When we looked at high blood pressure, high cholesterol, and diabetes by food security, again you see the same trend. Those who are food insecure had a higher incidence of high blood pressure. You can see it's pretty significantly higher. High cholesterol, it trended but that was not a significant change, but diabetes was as well. We looked at children in the Delta compared to the continuing survey of intakes by individuals. This is another overall study of everyone in the United States that's conducted by the USDA. And you know, if you look at the Delta, which is the first column, compared to the CSFII in the second column, you see that we have a higher percentage of male children that have that are obese, and a higher percentage of female children that are obese compared to their relative counterparts in the United States. You see the same thing with the racial comparisons, with whites actually being significantly higher than, I mean, that's one thing that I've noticed with this data, that African Americans or seem to be in most instances more like the African Americans in the United States in some of our data. The white people were much worse than the overall white population in some of our surveys, not in everything. But fundamentally, with the exception of this, the African Americans were always had a higher, they fared worse than Caucasians within the Delta, but not within the overall United States. The household income, you can see actually, you know, we're just worse in the Delta than just about anybody else in the United States. So, you know, I guess to conclude this portion, the adult population reported significantly more hypertension, diabetes, and obesity compared to the overall sample within the United States. Obesity was extremely common in all genders, race, and income levels. And when we controlled for age, income, and gender, the African American residents of the Delta reported more hypertension, diabetes, and obesity. So we have children also had higher prevalence of obesity compared to the national sample within almost every age and demographic category. Do you have any questions about that?
It would seem that this probably understates the problem because your sampling design missed the poorest of the poor who can't afford a telephone, since this was a telephone survey.
We actually, I have to address that. We did an initial comparison of an in-person versus a telephone survey, where we actually gave the cell phones to the people who did not have a telephone, and we actually conducted a smaller initial pilot study because we were concerned, because we had people going out and running the roads in the Delta. And we actually found that, number one, our response rates were very high on the telephone, and we did not see a difference in terms of, you know, to conduct the larger study that we've conducted, we could not afford to do it actually. So we were hoping that we would not find a difference between the telephone versus the in-person survey, and we actually didn't. But you do bring up a valid point. You know, the question is, you can't get the person who's very remote, that may be seriously at risk, may not be included in this. But just the fact that we found this data, as you say, may mean that there's other data that suggests that it is even worse. But it's bad enough here. I had a student, she's now in medical school. I don't know if anybody knows Anna, but she worked for me at the Pennington Center for a while. But she had done a study here at LSU as part of a honors thesis program, where she looked at acceptability of menus and recipes that met the dietary guidelines for Americans. And they did a series of focus group discussions. And, you know, sort of as a background, you know, we know that if we consume a good diet, that we may reduce our cancer risk, may reduce type 2 diabetes, hypertension, and cardiovascular disease. So through a series of focus group discussions, what was the point of her project was to determine why or why not low socioeconomic status individuals met or would meet the My Pyramid recommendations. They presented some 2-week menus that did meet the My Pyramid recommendations and yet were designed to be low in cost. The objectives of her research were to determine the predisposing factors of using the menus, obviously. And you know, as long as I've been a practicing dietitian, long time, people have, the number of people that have come to me and said, if you could just give me a plan, that's what I need is a plan. And you know, that's the worst thing. I think that you need to know what to plan and how to plan it, but for me to give you a menu, it might contain things that you really don't want. So what are you going to do about that? So you have to figure out, you know, that I would be rich if I developed, and I have developed many, many, many meal plans over my career because that's kind of what I do. She wanted to determine what, you know, factors went into getting the people to actually use the menus or were perceived as barriers, and also to determine the acceptability of the menus. So they had 4 focus group discussions, and the questions that were used in the focus group were designed to see what the predisposing factors were, the enabling factors and the barriers to following the menus, and also looked at the acceptability of the menus. They had a total of 40 participants who were, you know, about your age. Most of you in that age, right? 37? Just about. 23 were male and 17 were female. And I will have to tell you that it's surprising that she has that many males, because in a lot of the research we do, men do not want to participate. She had 26 African Americans and 14 European Americans. These are the places that the focus groups were conducted: Reality House, St. Paul Catholic Church, St. Vincent de Paul Shelter twice. So you can see that they were actually designed to look at people who were impoverished in determining how they get better food. The predisposing factors were knowledge, good taste, family background, whether they were dependent on drugs or controlled substances, family, food lore, and differing beliefs of what is healthy. And I'm sure we have lots of beliefs about what's healthy and what's not. So as you look at the breakdown, you'll see that taste was one of the main things that sort of filtered through every single focus group discussion. It was one thing that they talked about.
What do you mean by poor taste? Taste bad? Or that they have a bad sense of taste? Or
The barrier was that the food didn't taste good. They didn't like the taste of the food.
Did she prepare the food or give them the food to do it themselves, or they had to find the food and then prepare it?
I think that she gave them the recipes and the menus, and it was prepared in those shelters. Because they had to have a central place to prepare the foods. So they couldn't actually say it tastes bad without actually tasting it. I guess in terms of whether they would be able to prepare this food themselves, you know, you see a couple of times that there's a lack of food preparation skills, because if people don't cook, my sister doesn't cook. I mean, the only thing she knows how to make is green bean casserole. She absolutely cannot cook, but that's the only thing she made. Every holiday, we got a green bean casserole. But, you know, so I think that there's a lot of people out there. I know people whose husband cooks, and, you know, and my son is like a culinary person, and I have to cook for him. Amazing. But anyway, food preferences too were part of each of those. So that, you know, the barriers to actually adopting other foods really sort of stems from, you know, whether you like a food or for everyone, and whether you would prefer something else. So, you know, I might have green beans, you prefer broccoli or whatever. The most acceptable menu or recipe items, you can see oven-fried pork chops were very, very high on the radar screen, as long, and a Cajun jambalaya, Cajun spiced chicken, tuna salad, and broccoli cheese and rice casserole. These people must have been in Piccadilly. That's where the first time I ever had broccoli rice casserole was at Piccadilly. The most unacceptable items were chili and rice. I don't know that I would combine those two, chili, and maybe it was the way that it was served. How many of you have rice with the chili? Some people do, but a lot of people just like have, you know, when I fix chili, I usually have chili with beans, and it has, I sprinkle cheese on it and have a piece of cornbread. They didn't like that. I don't know why they did not like ham and black-eyed pea soup with, well, maybe it's because it's soup.
Also, cultural association of that's what you ate when you were poor and couldn't get anything else.
That could be that. Garden coleslaw, I think maybe just some people don't like cabbage as much as other things. And pot roast, I don't know why pot roast made that list, but maybe it was the way that it was prepared. But, you know, the barriers is that, you know, the main barriers were that they preferred other foods. This again goes to the, you know, the menu plan that you want that you really don't want. Cost and spoilage of food. I think they were asked questions about whether if they prepared these on their own, they would be concerned about the cost and the spoilage of the food, especially if they had to buy a lot of foods in order to prepare these. There was an actual or perceived lactose intolerance, and I think a lot of African Americans often assume that they're lactose intolerant. We have data to suggest that they need to try the milk to determine if they're lactose intolerant, because the actual lactose intolerance, I believe, has been defined at 10% of the population as opposed to a perceived 30%. Lack of availability of foods. Obviously, if you're living in a shelter, or you know, you may not be able to go to get foods. The food preparation skills and access to a refrigerator or a kitchen. And the discussion that you know, there was a preference for energy-dense food. I think for some of the same reasons that I mentioned before about people who are food insecure. That basically they want calories and they want to feel fuller for a longer period of time, and I think that's why we see a lot of energy-dense foods. They prefer refined grains, sweets, and meat, and it sounds like my brother. And the convenience and the taste are the two things that dictated that. The preference for white bread was, I think a lot of people have not adapted to wheat bread. They don't like the taste of it. I think, you know, in order to make a change in your life for to be healthier, you really need to slowly integrate these things and then sort of migrate. I do not buy white bread except for Poop Art's little French pistolets. That's the only white bread that I like because it's from my area, and it's a little small French bread.
Yeah, just a quick question. I was reading about how they're actually making wheat bread like white bread. They add all these flavor enhancers and make it soft. And
they do. They actually add inulin, which is like you know, a fibrous. It's a fibrous. It's kind of like some of these. I can't really explain how it is, but it's not a whole grain. So even though but I'm still concerned about the fiber content of the diet, so I would encourage you to get that over white bread. But
they also have white bread that's supplemented with sawdust or something, so it's like
that's what it is, sort of. That's what he's talking about.
He's talking about supplementing wheat bread to make it more palatable. I thought.
Well, they make it softer, so it's more like white bread. They actually
Right,
They have all, like, all these
just,
ingredients.
the main thing is when you look at the ingredient, the first ingredient has to say whole wheat flour. And then if it says whole wheat flour and it has a, for instance, on a per slice basis, ideally it should have at least 3 grams of fiber per slice. So that's how I evaluate things like that. But, you know, we don't see a lot of, in fact, even in Europe, I've traveled in Europe a bit, and you can't find wheat bread hardly there either. There's the cost and spoilage. You know, pretty much what they said is fruits and vegetables are expensive. Probably they're expensive even, and they may spoil quicker, so. The perceived intolerance of lactose, and you know, 20% of the participants reported being lactose intolerant. I think that the other thing is that we don't, you know, once there, you should look for a source of calcium or dairy. So often people who are lactose intolerant can stomach yogurt, can eat hard cheeses, and also too, you know, we have a supplement, lactase or lactate and lactate milk that you can purchase. As far as no access to a kitchen, some of the participants were homeless and they relied on the shelters. They also relied on some forms of fast food, probably because it's cheaper. Bread, crackers, and water. Multivitamins, I'm not sure that they were taking any, but that they also looked at, they may have taken some cheaper vitamins in order to get some level of nutrition, because, you know, that's what I tell people. You know, they say, you know, do I really need a vitamin? Well, you know, if you question whether you're eating correctly, then to me a vitamin is like an insurance policy. But it doesn't have to be a very high-end vitamin. In fact, I take a mature vitamin. I don't know why, but anyway, I use the Walmart brand or the store brand of a Centrum-like product. So it doesn't have to be Centrum. It doesn't have to be some special vitamin. And I think that some of the people really complained that portion size was a problem. You know, that's why we have supersized things nowadays. But, you know, so the residents of rural areas, you know, based on the first presentation that I gave you, and specific subgroups, demographic subgroups are really at greater risk for health problems. In the lower Mississippi Delta, food insecurity was double that of the United States levels and linked with poor health status. And also urban areas, as just discussed, are also affected. And I would very much be happy to, I actually did a paper in 2007 in the Journal of the American Dietetic Association that looked at poverty and food intake in rural areas, and with the subtitle that diet quality is lower in food insecure people in the Delta. So I'd be happy to answer any other questions that you might have. Yes, sir.
Thank you for your presentation. 2 areas I would like to hear you speak more on. The impact of institutions, schools, for example. I think the Army, was the Army that was within a week talked about the impact of the American lunch. On obesity and how that kind of fast food model kind of primes children for what they want when they're away from the school. When I was in the Marines, even in an institution where maximum physical performance was key, the foods that were in the vending machines were always, you know, the fast food stuff. So the impact of institution, because sometimes they can counteract the bad habits in the home. That's one area. And then the other is public policy. What the USDA, for example, for a long time put, I think, an unnecessary weight on dairy and meat at the expense of vegetables and healthy grains,
Right.
and then how we subsidize corn and potatoes, which are then used to make high fructose corn syrup and all this range of interesting products that people are lined up at midnight outside of Taco Bell's to get.
Well, let me just say I've been involved in school lunch efforts in Louisiana for a number of years. We even went so far as to put together a teen nutrition training grant some years ago, and now I'm involved now in another teen nutrition training grant. You know, USDA and, well, the nutrition portion of school lunch has had a bad rap for quite a few years, sometimes justifiably so, but more so, I think, from the standpoint of implementation on the local level of what happens in our schools. You know, they've published a whole compendium of healthy recipes, and you know, I think that at the local level there's a barrier in some instances by wanting to give wanting to see the children happy. So the children are influenced by what they see, like fast food. So they try to get, you know, for instance, they'll have chicken tenders, but the chicken tenders that school lunch approves are a healthier option than other chicken tenders. So they're trying to sort of mimic, and I'm not sure that that's to their advantage, to mimic what they can get in terms of a fast food-like product in order to keep the kids happy. They have healthy pizzas, they're getting whole grain pizzas now. So, but I don't know that it's
A whole wheat donut is still a donut.
well, they're not, they're doing whole wheat pizza crust. But, you know, but still, your point is well taken, that what we have seen is we've seen an infiltration of any kind of a fast food marketing. Marketing is really where it's at. So, and we haven't done as good a job at marketing what's healthy as opposed to what people want in terms of taste and convenience. Convenience is a big factor. Taste, convenience, and price. So to get healthier, but you know, and I'm seeing the same things. I'll get to your question in just 1 second. But I will tell you that we are now working with the Army to improve their dining facilities. It's the same problem at a larger scale. And where we think that we're going to make the most impact is where we talk about nutrition in terms of excellent performance. Nutrition driving performance. So we're getting ready to launch, you know, some more studies in dining facilities where we know that we have a specialized, like the Rangers, the Green Berets, the Navy SEALs, that type of a unit that they are going to be sort of like on the highest level of really knowing that performance is key to them. Once we can get these guys on, then I think we can, and the same thing in schools. Now, you know, yesterday I was at the Capitol with energy drinks, and, you know, that's a growing problem as well. And so I have a, you know, they'll never get it passed, but whatever. I'm all for it.
But don't we have a lot of fast food here? Because that's what the consumer wants. And if you go to Europe, you go all over the world, why is this spreading over the world? Because that's what the consumer wants.
Exactly.
Why are sizes, servings bigger? That's what the consumer wants.
Exactly.
It's convenience and taste all over again, and that's what the consumer wants. And so, and how can you change what the consumer wants? That's the challenge, not what the fast food has, because you can go in fast food stores, they'll offer salads, they'll offer fruits, they'll offer, you can see all sorts of stuff. But you watch who's ordering those, you won't see very many, and if people don't order those, they're not going to keep selling those, offering those things to people.
Well, and that's true. That's why McDonald's got rid of their McLean, because they had it there, it was an option, but nobody was buying it. So, I mean, you're exactly right. The thing that's going to make things change, as I see it, are people increasing their level of disease, dying sooner. We have a problem with childhood diabetes, and it's not the childhood diabetes, it's the obesity onset diabetes that's happening in children who are never had diabetes before. So, you know, this is, I mean, I think that's what it's going to take, is for the consumer to want something better, and some of them do. But until we see McDonald's closing up, I think we're going to have a problem.
But see, to me, the other piece of that, though, is the marketing and the way the marketing drives what the consumer wants. I mean, you know, probably my favorite statistic related to this is, you know, taste. We think, well, that's sort of, you know, everybody has their own taste. Well, I've seen one survey of children that they said the macaroni and cheese that's regular macaroni and cheese doesn't taste as good as the SpongeBob SquarePants macaroni and cheese. Completely the same stuff in it, but the fact that it's shaped like SpongeBob makes it taste better? No, it's something that's fed into our heads. If you look at the television that children watch, you won't see television ads for fruits and vegetables. You'll see television ads for sugar cereals and McDonald's and all that. That's where it's getting fed in. We're not born, I don't think, with this proclivity to say, I want fast food. But that's the nutrition, the easiest nutrition information to get is on commercial television.
Oh yeah, I mean, I agree with you. That's why my comment about, you know, where do you find the sugar-coated cereals? And actually, your comment about corn and, you know, high fructose corn syrup, you know, that was a cost maneuver by the beverage industry and actually other industries as well, but beverages are much more of a concern because we saw the #1 contributor to dietary intakes was it's often sugar-sweetened beverages. But, you know,
they're going back to sugar. Yeah.
They're going back to sugar now because the corn is getting more expensive, so it's really a cost that's driving it.
Right.
But you know, high fructose corn syrup has gotten such a bad press that now people are demanding something else because they don't want that high fructose corn syrup. You know, we need to do as good about certain things as we have about smoking, for instance. People, I mean, if we could attack many of the, but it's going to be like a one, you know, we need to spotlight one thing at a time. For instance, like high fructose corn syrup, I think has had enough bad press that people are now looking at food labels because they don't want it.
But part of high fructose corn syrup came out of farm policy in the Nixon administration to say we're going to grow as much corn as we possibly can.
Yes.
And then we're going to figure out what to do with it, and that was one of the things to do
And
with it, which drove the price down.
And there's a little movie about that I saw at one of the obesity conference. I think it was called King Corn.
Yeah, it is.
And that was a very interesting movie. It was free for us to see, and it was like very compelling.
I have opportunity, well, where I work, we run an early head start, and the kitchen is next door to my office, and then I'm in schools a lot, and I'm there for meals. And I'm astounded at what is thrown away. And early head start has very high standards for what can be served. And it's been so nauseating to see this food dumped that I've actually said something, and I've been told we must give them a certain portion by law.
Yes.
And we have to put everything on their plate by law. And when I hear, because I watched, you know, Jamie Oliver did his school lunch thing about 10 years ago in Britain, and we watched that series. It was fascinating. Now he's doing it in Virginia or someplace. And again, they only get $1 and change per kid, and when you have to put X amount of applesauce on the plate or peas, you know, they're giving these 18-month-olds a big old honking serving of peas, and
Now,
of course
you
they're
know,
gonna throw it away.
I'm not as much aware of the Head Start
Oh, they have really
guidelines,
strict
but,
rules.
you know, in the elementary schools, you know,
Oh, they
they would
must.
be, they have to provide them, I think, it's a certain percentage of the estimated energy requirement for the day.
I just can't see it because it
I
gets
know
thrown
it's
away.
20.
And why can't they go
Well,
ask for a second helping?
But then counter to that, if you serve less, or you let the kid serve less, then they're gonna be faulted for not providing.
If they have a second flight, and when you say something to staff, they say, we're not allowed to encourage them to eat. You're not allowed to put food pressure on kids to eat. And you know, I mean, we are talking, I go to Iberville Parish, gorgeous chicken leg, beans, peas, mashed potatoes, you know, Jello for dessert, full, big old milk bottles, and it is just pitch. Plate after plate after plate. They don't know what to do with the real piece of chicken that has bone in it. I couldn't even bear to go to lunchroom. I stopped going
Have you
because,
seen our day school's lunch?
yeah.
leftovers?
Miss Diane says they have things they eat, and they won't let her cook those things, and they have to have variety, and they just pitch it. And when I think of the food costs, and they're not allowed to encourage children to eat their meal, then what's with that?
Well, you know, I went to elementary school in Catholic school in St. Martinville, Louisiana. And you know, they told us that when we went out for, when we went to lunch, you know, the nuns would always say, think of those poor kids in China that don't have anything to
Clear
eat.
your plate.
And it was kind of a clean your plate sort of thing, but, you know, we were young.
These
Like,
are very
it
low
made
income
me
children.
feel guilty if I didn't know peas.
And they're always encouraging them to eat it. They eat
Good.
wrong.
Thank you so much.
Yeah, it's right at 1 o'clock. I'd like to thank Dr. I was going to ask you, have you read In Defense of Food?
I read Fast Food Nation. I'm switching to
This is real good.
Sugar-free?
I asked Carol, and she said no.
No,
Sugar-free hazelnuts
Okay.
from CC's.
I guess I'm too busy.
I went and just bought a bottle.
Right.
The ice cream.
What's wrong? It's the same thing.
CC's was an actual. Sure.
Have a good day. Have a good day.
Dr. Sun.